Yes, it's okay.
Okay, great. So thanks everyone. Welcome to today's APSC CME series live in the box with a focus on renal denervation. Today is the 12th of January 2024, Friday, 3 p.m. Singapore time. This event is organized by the Asian Pacific Society of Cardiology, endorsed by the Singapore Cardiac Society, the PCI chapter, accredited for CME points by EBAC in collaboration with Medtronic. My name is Jack, and your host and chair for today from Singapore, past president for APSC. We're very privileged to have two esteemed speakers with us today to take us through two very important topics. Professor Alta Schutte is the principal team lead of Cardiac, Vascular, and Metabolic Medicine at the University of New South Wales, Australia. She's going to talk to us about treating patients with hypertension in 2024. Are the current guidelines addressing all the unmet needs? Dr. T.K. Ong is consultant and head of department at the Sarawak Heart Centre, Malaysia. He's going to tell us how he sets up a RDN service. We have two other speakers who are going to take us through cases from the other side of the globe. Professor Atul Pathak, head of cardiovascular medicine from Princess Grace Hospital, Monaco, is going to talk to us about when the patient has a right to decide. Dr. Nabil Ismail, section head adult cardiology at King Faisal Hospital and Research Center in Jeddah, Saudi Arabia, is calling in actually from the United States today, and he's going to talk to us about a complex case of refractory hypertension. To discuss these cases with us, we have some panelists from across the region. Dr. Siripon is from King Chulalongkorn Memorial Hospital, Thailand. Dr. Chia Yok Chin, primary care physician, is from Malaysia, Sunway University. And of course, Dr. Paul Ong from Novena Heart Center, Singapore. Some housekeeping. This content is copyrighted by the APSC. The views and opinions expressed belong solely to faculty members and do not necessarily represent those of the APSC. The webinar is now live streamed via Wonder, APSC Facebook and YouTube pages. CME points will then be submitted for those who are connected throughout the full duration after completing a survey. A pitch for upcoming webinars on the 7th of February 2024, we have our next installment for our APSC EECC Core Cardiology Review Series on heart failure, episode 6. So let's get started without further ado, and I would like to welcome Professor Alta Schutte to talk to us about what's new in 2024 in the guidelines in addressing the unmet needs in hypertension. Professor Alta, please.
Thank you very much. It's quite a pleasure for me to be here today and speaking with you all. I'm just checking you can see my screen, right?
Very well. Please go ahead.
Excellent. Thank you so much. So yes, quite an important topic to start off with this conversation today on renal denervation. And that's firstly to look at the current situation on patient treatment. So the question is, are the guidelines currently efficient to really address the treatment of hypertension in 2024? And are current guidelines addressing the unmet needs? So to just set the scene a little bit, I think it's important to just re-establish that if you look at global data, also those from the global burden of disease, it is clear that raised blood pressure remains the leading cause of death in the world. And in the year 2019, it accounted for 10.8 million deaths, which is about 20% of all deaths in the world. And that accounts for about 30,000 deaths each day. If you rank the different risk factors for death, you can see that high blood pressure is by far the leading risk factor, followed by smoking and other risk factors such as blood sugar and obesity. But it's really a main factor, and if we don't address it appropriately, it obviously will lead to more strokes and heart attacks and other cardiovascular consequences. But to address hypertension, you have to look at the full picture. You have to first identify those individuals with hypertension, have to make sure they are aware of it. We know about half of people with hypertension are not aware of it. Have to make sure that they do receive the appropriate treatment and hopefully get them to control. And the one aspect of this cascade is actually dependent on the previous one, and there's many places where things can go wrong. For example, people remain unaware of the fact that they have hypertension, thus cannot be treated, or they do receive treatment, but still blood pressure remains uncontrolled and they remain at high risk. So just briefly, in terms of awareness, as I've said, about more than half of people with hypertension are not aware of their high blood pressure, and therefore the Lancet Commission of Hypertension a few years ago said that every adult should know their blood pressure. So the importance of screening and measuring blood pressure at every clinic visit is actually quite important to make sure that people don't fall between the cracks. But mainly we will focus on treatment today, and in terms of treatment, just a recap in terms of some of the key messages of guidelines. It's really important to treat blood pressure effectively. Two different meta-analysis and systematic reviews really shown that if you just look at the relative risk reduction, when you decrease office systolic blood pressure, you can look at the light blue bars from the one systematic review, show that if you reduce systolic blood pressure by 5 millimeters of mercury, it will result in a reduction of risk for major cardiovascular disease events of 10%, or 13% for stroke and heart failure, or basically the same result from another review. If you reduce office blood pressure by 10 millimeters of mercury, it results in a 20% reduction for major cardiovascular disease events, much greater even for stroke and heart failure. So there's real benefit in reducing blood pressure effectively, and each millimeters of mercury actually counts. And one of the ways that we do that, and that all basically major guidelines recommend these days, is by using fixed dose combination therapy as first-line treatment for managing hypertension. And as indicated in this paper already in 2019, emphasizing that also the World Health Organization now has fixed dose combination antihypertensive drugs on their essential medicines list, and emphasizing in this paper also that it is safe to actually initiate therapy with single pills, because that's often one of the barriers that clinicians believe that there are safety issues. So since then, and also it has been adopted by many guidelines, as shown here, for example, by the 2020 International Society of Hypertension guidelines, which indicates that for all different steps of managing hypertension, to ideally start or use single pill combination therapy, starting with dual low dose combination of an ACE inhibitor or ARB and a calcium channel blocker, going to full dose combination, then a triple, etc. And if I just follow on that, the WHO guidelines released in 2021 also recommended starting with combination therapy, ideally single pill combination. So it's really quite a consensus in international guidelines. So in 2018, the European Society of Hypertension had guidelines, and they were some of the first to recommend single pill combinations. And what I will emphasize a bit more today is the 2023 guidelines from the European Society of Hypertension, which is the most recent guidelines released. And these guidelines also start with dual combination therapy in most patients, starting with either, again, an ACE or ARB plus a calcium channel blocker or diuretic, and then increasing the dose and so forth. I will get to these sections a bit later. So it's really important to just state why single pill combinations are so effective. It is simply due to, there are several reasons, but one of the main reasons are reducing pill burden. As we know, people with hypertension often have many other comorbidities and therefore have several drugs that needs to be taken. But by simply increasing, for example, patients' pills, number of pills from 2 to 3 drugs, double their likelihood of being non-adherent to their medication. And as the number of pills increase, the number or the likelihood of having non-adherence increase again. So by reducing the number of pills for patients with hypertension to a single pill is likely to have major benefits in terms of adherence. And this has been shown also by a systematic review and meta-analysis, which was shown all different studies actually favored fixed dose combinations for achieving better patient adherence to medication. And another one also showed, another meta-analysis showed that a single pill combination resulted in better blood pressure control, not only adherence, but actually resulted in better blood pressure control than free combinations or monotherapy. So the evidence is accumulating, and more recent work has just continued to emphasize this. And this is why it's been quite a key feature of all these different hypertension guidelines released. So yes, we have this from the International Society of Hypertension, but a key fourth step in these guidelines are patients with resistant hypertension. So that means the patients have been taken these drugs as indicated in the previous steps. They are adherent to those medications, but their blood pressure remains uncontrolled. And that is a very specific patient population that we will also discuss a bit more today. In the 2023 guidelines from the European Society of Hypertension, it's nicely shown that if you start with these different pharmacological therapies, you can get up to 60% of patients with hypertension having control. And if you increase the dose, up to 90% will actually have their blood pressure controlled. But there remains a persistent approximately 5% of patients with true resistant hypertension. In other words, blood pressure remain elevated despite them taking all of their medications as prescribed. So as I've mentioned before, the European Society has released guidelines in 2018, and in these guidelines, as was shown in that previous slide, they recommend that if blood pressure is not controlled, continue with a 3-drug combination, not controlled with the 3-drug combination, then add another drug like spironolactone or other additional antihypertensive therapies like amiloride, etc. But this has been updated now. In the 2023 guidelines, there's been quite a major change. And for the first time, so the drugs section has remained practically the same, but there's been a new recommendation on renal denervation where it's clearly indicated it can be considered now as an additional treatment option in patients with resistant hypertension if the GFR is greater than 40. So this is an important new addition which really opened new pathways for additional options for treating patients with resistant hypertension. And of course, there will be lots of talk today about renal denervation, but clearly it is a very effective strategy to interrupt sympathetic neural activity between the brain and the kidneys. We know that sympathetic activity is one of the main drivers for increasing blood pressure, and by disrupting this communication, it has a whole systematic effect in terms of sympathetic tone, which is also often lasting long for several years. So it's quite an effective approach, and now clearly recognized by the latest international bodies to actually be an important treatment strategy. So in the 2023 guidelines for true resistant patients with true resistant hypertension patients, it is shown in this flow diagram. So they are not controlled with traditional antihypertensive medication. And for those with a GFR greater than 30 or CKD stage 1, 2, 3, different drug options are shown, as I've mentioned, spironolactone, etc., but then clearly indicating to consider renal denervation for specific patients if GFR is greater than 40. In the 2018 guidelines, I'm just making that comparison to show that there's been some real recent changes which we need to be aware of. There was a specific section on device-based therapies for hypertension, and it was strongly indicated there that the use of device-based therapies is not recommended for the routine treatment of hypertension until further evidence regarding their safety and efficacy becomes available. So importantly, during the past 5 years, there's been some important new studies published in this space. And that resulted in 2023 for the European Society of Cardiology to publish a clinical consensus statement showing there's been several recent randomized clinical trials clearly demonstrating blood pressure lowering efficacy and safety in a broad range of patients, including those with resistant hypertension. And this was also then adopted by the European Society of Hypertension, as I've shown before. And this is my last slide, but I want to emphasize a few aspects here from this extract from the ESH guidelines. As I've mentioned, is for uncontrolled blood pressure recommended, but also for resistant hypertension. So for both these conditions, it's recommended for uncontrolled blood pressure in patients when antihypertensive drugs are not effective, or there's specific side effects or poor quality of life that makes the drugs not the ideal approach. So then it can be considered, and also, of course, for resistant hypertension. And these last 2 points is about the selection of patients. There will be some talks about this later today, but it's important that it's done through a shared decision-making process with the patient. It's not a one-sided decision because it's very different from previous approaches, but also it should be performed in experienced centers. So there's clear technique involved with doing renal denervation and how to select the patient, how to perform the technique, and therefore this is also an important class of recommendation from the European Society. So I'll stop here, and thank you very much for your attention.
Thanks, Professor Alta. Indeed, very, very excellent, succinct run through the guidelines and addressing some unmet needs. We have time for some discussion. Any questions for Professor Alta from my panelists or the audience? Please go ahead. If not, maybe can I clarify one of the treatment option, which is considering in the refractory or poorly controlled hypertensive, offering RDN as an alternate. And in the CKD patient, stage 4, 5, you don't have that option. Is it truly just because of the contrast use, or we think that there's insufficient evidence to offer RDN in those with already late-stage CKD? Prof. Alta, do you have any opinion on that?
Yes, I'm happy to also open up to the other panel members who are perhaps more experienced in actually performing the technique, but I do believe it has to do with kidney function in itself, because it's also an intervention technique that are directly affecting the kidney. So if GFR is reduced too much, it may obviously have further implications.
TK, do you do any late CKD patients for this RDN procedure?
Yeah, I think for patients with still has preserved renal function, 30 GFR of 30 is the cutoff. Below that, we are a bit concerned about the contrast. For patients in CKD5, which means they're already in end stage, it probably does not matter. You have no kidney to preserve. The only thing is that we don't have evidence, because all the studies on renal denervation actually use 40, GFR 40 as a cutoff. So patients GFR below 40 were not recruited in any of the studies. So they cannot make any recommendation for patients with more advanced kidney disease. But that doesn't mean that they don't respond, because we know that patients with advanced kidney disease actually have higher sympathetic tone, So they might actually be the best patients to undergo renal denervation. Yeah, but I have one comment, or maybe I don't know what is a question or comment for Professor Schutte, because in your presentation you talk about the 1 drugs and 2 drugs, and with the combination therapy, when we go up to 3 or 4 drugs, we can achieve control in 90%, roughly 90% of patients. So the true resistant hypertension is actually very small, less than 10%. But if you look at, well, it looks like the drugs are fantastic, they work, and the landmark trials for those drugs shows that they work. But if you look at real world data, patients actually achieving control, hypertensive patients is actually around in the region of 40 to 50%, So it's not just an issue of whether the drug works or not work, isn't it? It's many other factors as well.
Thank you. That's such an important point. And I think there are several implementation issues at play and behavioral issues. One, for example, is that treatment inertia is such a big problem. So when patients are diagnosed with hypertension and medication is given, it's often not effective enough to reduce blood pressure to target. But there's major resistance to then up-titrate at the next visit. There's been a very recent study in the Journal of Hypertension showing only 10% of patients medication have been up-titrated at the first visit after the original diagnosis, despite their blood pressure being uncontrolled. So this is whole aspect of treatment inertia, not up-titrating treatment, and then there's these issues of medication adherence, patients not taking their medication. I'm sure everybody's familiar with that as well. And there may be several reasons for non-adherence, whether it's to do with cost, availability, or other behavioral issues, side effects, etc. So unfortunately, we have these challenges. We have very effective medication, right? So patients need to take that, and clinicians have to make sure that it's prescribed appropriately, and that relationship with the patient, and it maybe comes back to that shared decision making that's coming up later today. But that relationship between a clinician and a patient is actually so important to make sure that there's this discussion and insurance that medication will actually be taken. Otherwise, the risk will remain high.
Paul, you have a comment?
I have two comments. I really enjoyed the talk early on, and I fully agree that, starting off the new guideline with the fixed dose combination is really good, because as you mentioned, getting the patients responding to the initial therapy is really important to gain the confidence to carry on. I have a comment about the renal denervation in renal impaired patients. I also have some concern that when doing these procedures on patients with atrophic kidneys and also with already have underlying renal artery disease, a lot of time in patients with that degree of renal impairment, the renal arteries are also really terrible, not really ideal vessels to do denervation. My question now is, I think perhaps the other speakers later on would touch on that, is if there's an inertia to even up titrate, or for the patient to allow you to up titrate the drugs, wouldn't it be even more of an inertia to convince the patient to go on to the path of renal denervation?
Dr. Atul, do you want to consider taking that question? When do you agree with the guideline saying that as equivalence, once you're across 3 agents, you are labeled uncontrolled or refractory? And is it easier for you to convince a patient adding on medication or compliance versus RDN management?
Yeah, I think it's an interesting comment. There is a discrepancy between what you think patients are doing and what they really do. What we have learned from trials, and especially from renal denervation trial, where for the first time we were able to assess the presence of drugs in urine or plasma, is that when you prescribe more than 3 drugs to a patient, 50% of these patients are not taking any of them. So this is, I think, a very important point, showing that what we think is a resistant, refractory hypertensive patient is probably a non-compliant patient. Second, what we have learned is that it's a dynamic behavior. You could be non-compliant at the beginning of a trial and suddenly compliant 3 months after, and vice versa. So the difficulty behind everything we are sharing today is very complex to understand the way a patient behaves in front of a disease, whether it's compliance to lifestyle modification, compliance to drugs. I would say the good thing with renal denervation is that when you have done the procedure, you have done it. So patients have been exposed to the procedure, which is not necessarily the case with drugs. The problem with renal denervation is that, and you will see that there is a huge variability in response. So, and we don't know who is the right responders to the technique. So despite having something which can help us to control blood pressure, which help us in patients who are non-compliant, we are still struggling to identify good responders and to be sure that by offering renal denervation, you will win the match and bring the patient to the target.
Thanks, Dr. Atul. I see a lot of good questions by the audience, particularly about RDN procedure. When do you see the effect? How durable is the effect? Is there any RDN effects beyond just hypertension control? We will defer that until TK's talk to answer those questions. Dr. Nabil, you were busy typing some answers to the participants. You have any comments or questions?
Yes, so two comments actually. First of all, regarding patients with chronic kidney disease, although they are systematically been excluded from these clinical trials, but from real-world data, we have accumulating evidence that it is actually effective. And as you guys mentioned, that although giving the contrast is something that we are reluctant to do with these patients. We need to keep in mind that hypertension is the most important enemy for patients with chronic kidney disease, that we have to take it really serious and try to control it to minimize the decline in patients with chronic kidney disease. So either we use it with caution, or we sometimes consider using CO2 as an alternative to iodine-based contrast to do the renal denervation. And that procedure that has been done, and we do it in our hospital as well. Now, one of the questions that I actually answered was regarding the duration of the effect. So far from registry data, we have at least up to 3 years of sustained results of successful renal denervation effect on controlling blood pressure.
Thanks. So at least in the mid to term, it seems to be working well. That's our shared experience as well. So we're going to move on, but just quickly a few observations about the talk in general. Hypertension is not sexy, I can tell you that, but it is the largest and most important killer in my part of the world, particularly in Southeast Asia, Indochina. The rates of death attributable to hypertension is the highest among all the risk factors, including diabetes. But it's just not so sexy. And the main problem is that we are so focused on guidelines that addresses the people that actually see you, but the bulk of people in this region are actually not diagnosed. There's actually not enough awareness to diagnose them. They are still distressingly the #1 cause of end-stage renal failure in our region, as well as stroke. And that's the first time they get diagnosed with hypertension. So we are still doing very poorly in under-diagnosing them, and even after diagnosing, the inertia of under-treating them, and finally controlling and encouraging compliance. The implementation is a problem. So RDN may be an adjunct because it's an always-on effect. It excludes all this compliance issue, but definitely it's not applicable in the broad range of epidemiological needs in our region, with in the lower middle-income countries. So we're very keen to explore a lot more in the following sections. In regards to the CKD part, the reason why I asked a question is that we can have techniques that doesn't use contrast, but I think we still need probably more evidence to show that it works, because the CKD subset, we don't really quite handle how to arrest the progression and the event rate reduction at the moment. So we're happy to call upon TK now to show us, because there's so much question on RDN now, how to set it up, how is it done, what's your experience? Thanks, TK.
Okay, thanks, Jack. So I'm asked to talk a little bit about how to set up a renal denervation service, because I do have one in my center. Of course, I wouldn't say it's super active, but we have an ongoing service. And I am going to talk from my own experience, so it might not be applicable in all geographies, But there are many things to talk about when I was thinking about how to set a service. So many things. You think about the training of the team, talking about the funding, getting the patients. There are many things to talk about, and there are many challenges. However, I think the training of the person, the person who do the procedure, that's the easiest part. It's such a simple procedure. I think any interventional cardiologist or radiologist can be easily trained to do renal denervation. So I'm not going to talk about that, right? It's not much to talk about there. Funding is an issue that's not easy to overcome in different health systems with different challenges. Again, but then it's not something that we need to think about when we set up a renal denervation service, right? So when I think about all these, I think that the most challenging component of setting up service actually to get the patients. Because in my center, the treatment is free for my patients, we do have a team, and yet we're not seeing huge numbers of patients. We're not getting the referrals. And so I think getting the patients for renal denervation, I find, is the main challenge when you start a renal denervation service. We have seen this slide before, the latest ESH guidelines for hypertension. And you can see that in these guidelines, and as with many other consensus statements or guidelines or position papers, renal denervation has been recommended for patients with uncontrolled or resistant hypertension. right? This is universally accepted. If your patient has blood pressure that's high and cannot be controlled, then you should consider renal denervation. Similarly, this is our Malaysian consensus, and you can see that in line with most guidelines at this point in time, we do not recommend or suggest that patient be subjected to renal denervation as first-line treatment for hypertension. You see, it comes down right at the bottom, right? After we've excluded all other possible reversible causes of hypertension, in particular, secondary causes. You can see that the workup for resistant or uncontrolled hypertension is quite laborious. There are a lot of things to be done, right? In particular, assessment for secondary causes of hypertension. And I think herein lies the problem, because the majority of patients with hypertension, at least in our setting, but I suspect it's the same in many other countries, the majority of patients suffering from hypertension are managed in the primary care. And so the primary care physicians or GPs, they do not have the time to do all this, or they do not have access to all the, to all these tests that you need to do to rule out secondary causes, or to even ambulatory blood pressure monitoring facility is not available in all health facilities. So a lot of patients are being managed by practitioners who, just titrate the medications and hope for the best, and don't actually, work up the patient further and refer them for further treatment if the blood pressure is not adequately controlled. So to be able to have a successful renal denervation, I think the first step really is to develop a hypertension team. You need to develop, to create within your own institution, a hospital, a hypertension care team. It doesn't have to be renal denervation. It's just a hypertension team, right? So that they can focus on the management of patients with hypertension and consider all the options available, one of which, of course, is renal denervation. And once you have started this team and the service in your hospital, then you can start identifying the people out there, the other people who are managing patient with hypertension, so that you can educate them and get them to refer appropriate patients to you for the procedure. And last but not least, of course, we have to educate the patient, how well informed the patient are. Sometimes going for a new treatment is sometimes initiated by the patient. If the patient knows that such a treatment is available, they might approach the physicians and say, oh, I've read about this, is this available for me? Because my blood pressure is not well controlled. So education of the patient is important, telling them the options available, but also not just that, but also telling them about the risks of uncontrolled hypertension, right? So the identification of the healthcare, the people who look after patient with hypertension, we have to identify that, and we have to see among those patients managing hypertension, who are the ones who manage their patients the worst, right? Who are the patients with uncontrolled hypertension? Do they come from usually primary care? Not surprisingly, it might not be. The primary care physicians might be doing a better job than the hospital-based specialists, because we are so busy looking at other things that we don't, it's just a by the way thing, the hypertension, right? So we don't concentrate on it. So we need to identify these people, we need to identify the patients. Then we need to educate our physicians, our nurses who help us with monitoring the blood pressure, with following up the patients to not just in the hospital setting, but also in general practice. So general practice, secondary care, facilities, and tertiary care. So all these healthcare providers managing patient with hypertension need to be educated. And within the hospital, once you have started the team, right, you then need to identify, it cannot be just everybody within the team. It cannot be all the cardiologists or all the nephrologists. You need to identify specific people so that you can say, this is your job, right? You have to look after hypertension, and in particular, within the group of specialists looking at after hypertension, identify one or two who is in charge of renal denervation. And that does not have to be a cardiologist. That can be a nephrologist and a chronologist or whatever, whichever suits best for your hospital. Of course, most of the time, it tends to be cardiologists, but it's not necessarily the case. And therefore, if you have all this in place, hopefully you can have increased collaboration between the healthcare providers in primary care, with that in the secondary and tertiary, increased collaboration and communication, and that will help to increase the referrals of patients who are whose blood pressure is inadequately controlled to you for further optimization of treatment. So when they're referred to us, a lot of times these patients that will refer to my unit do not end up renal denervation, because we realize that although the physicians or doctors outside have tried the best, there's still additional things that we can do. And by doing that, like for instance, changing multiple drugs to single pill combination, things like that, right? And just by doing that, we can actually help to improve blood pressure control without subjecting the patient renal denervation. But certainly there's a group of patients where despite what you do, the blood pressure remains uncontrolled. And then this will be the patients that you should work on to control their blood pressure. Increased patient awareness, I've talked about. And this can be done in various ways. It can be done through, we've done in our place, I've done press statements and things like that, get the newspapers to help out in the health columns and write up on renal denervation. And so that patients are more aware. And so that when they see their own physician, they ask, oh, I've just read about this treatment in the newspaper. Is it available in our country or in a hospital? Things like that. So this is things that's important. Ultimately, of course, we are doing all this, not to increase the number of renal denervation procedures. It's not that we are dying to these procedures, right? We are doing all this ultimately to improve the blood pressure control of our patients so as to reduce the cardiovascular risk. So that is an important message, not just for the patient, but for the other physicians as well, the ones who are not doing the procedure. Because when you talk to them, they will be thinking, oh, you just want them to refer patients to you because you want to do the procedure, right? But it's not really, we are just thinking of the patient's cardiovascular risk. So that message has to be conveyed to the other doctors as well. Now, when we first started our renal denervation program, we followed this flow chart. First of all, we look at our existing patients, all right? Then after we're exhausted that, we don't, among the patients follow up in a cardiology clinic, we have no more patients with hypertension, then we go to other physicians and see whether they have patients that can refer to us. Then we look for doctors from other hospitals and other health centers. So we follow this. But then we realize that the pickup rate is very, very little. As you heard earlier from the first lecture, the incidence of true resistant hypertension is actually very low. Not many, right? So the pool of patients within your own cohort will be very small. So I think this is probably not the right path, right? The way to start is to get everything in one go, right? So you need to start looking at your own patients. You need to start getting the other physicians, other doctors in the hospital, as well as other centers involved, so they can start to help you to identify patients who might benefit from this treatment. So I think that's something that's potentially is more helpful, huh? And of course, support from your leaders, for your hospital administrators, leadership support is all important. It's very important. So you have to demonstrate, or you can show that the treatment is something that is accredited. Well, it's already in the guidelines, so that helps a lot. Previously, it was not in the guidelines, so they'll question you, well, it's not in the guidelines, why are you doing it? But now it's in a lot of guidelines and consensus, so that makes it easier. Funding is challenging to get that from the administrators, but to get funding from them, you have to demonstrate that the treatment works and that improves outcome. So you need to have outcome measures. And so you need to collect the data and show them with your data, right? So you need to share your data with them to show that it actually benefits the patient overall. The treatment might be expensive, but in the long run, by reducing admissions for heart failure or stroke or whatever, you're actually saving costs, right? So these are the things that we need to, data that we need to generate to share with our administrators. And of course, the use of electronic medical records are useful. It's very useful in this aspect, huh? So this is my last slide, okay, showing how we get the patients. So typically, of course, you have the green line shows where the patients come to you. And typically, there will be your own patients. So there are patients under your follow-up. So they might have other medical conditions, cardiac disease or kidney disease or whatever, but they also have hypertension. And from that group, you will have a group of patients with uncontrolled hypertension, regardless of what you do. Then these are the patients potentially can be subjected to renal denervation. But some of these patients do not come to you. They see the primary care physician, the GPs, other specialists, because their main condition might not be cardiac and you're a cardiologist, so they're seeing other patients. So you need to educate these other doctors so that they're aware of this alternative treatment. You need to tell them this is already in a guideline, this is available, and this can potentially help some of your patients so that those patients whom they are seeing, if the blood pressure is uncontrolled, can be referred on to you. And of course, we don't want to end up with all these patients. We don't become a hypertension. Some of us are for the proceduralists, right? We just want to help them with this procedure to improve the blood pressure control. So after we've treated the patient, then we would send the patient back to their primary care, primary doctor, right? Whether it's a specialist or a primary care GP. And within the hospital, for your renal denervation or hypertension or renal denervation program, of course, you need the administrators to buy in. They need to support you, to support you with in terms of fighting for the funds for you, in terms of supporting your application for funds. Sometimes that needs approval by the hospital administrators. And for that, you actually need to show them lots of data, and not just published data, because you need to show them from your own experience. You need to generate your own data, and so that, yes, show them that the results that you see in the clinical trials can be replicated in your own center by you doing the procedure. Because they'll say, oh, that's not in a big center overseas. You might not be that good. You might not get as good a result. So you need to show them that you can do just as well. And that's important to start and to sustain your renal denervation program. And that's it, I think. Thank you very much.
Thanks, TK. Maybe you can stop share for the time being. I'm just going to go around. TK make it sound so simple, but maybe I'll start with Sharipon first. What do you think is the greatest barrier for you in Thailand in starting a program out of all the barriers we talked about?
It's very important for appropriate selection the patient for RDN, because the first step is very important that the patient had resistant or refractory hypertension, that people control well lifestyle modification and compliance of medication and follow up. So we need to develop hypertension clinic like Dr. TK, and very important for educate the patient before decision to renal denervation.
So in Thailand, it's finding the patient. Paul, in your experience, what is the greatest barrier?
Yes.
I think we have patients like that. It's just convincing the patient and getting past the inertia to agree to a procedures. I find it difficult sometimes just to convince them to increase the drugs, to convince them to go for procedures. That's number one. The second part is the funding. Funding for renal denervation at the moment is not available in Singapore. The insurance company won't pay for it. I think, check if I'm not wrong, even in the government center, this is still not clear cut. So therefore, the cost of the procedure is also quite prohibitive.
Yeah, so it's about money as well as convincing and overcoming initial. Dr. Nabil, in Saudi Arabia, where money is not an issue, I'm sure, what is the main problem in setting up a program?
So, well, it's not that the money is not an issue, but I mean, we try to apply evidence-based medicine as we accumulate data from the ongoing clinical trials and real-world data and registries. We are getting more and more patients, as was nicely illustrated by Dr. TK, that the more involvement of or the more the increase in the awareness in the public, as well as in our colleagues who are usually treating blood pressure or hypertension, whether they are primary care physicians, internists, and nephrologists, and other cardiologists, they need to understand that there is actually a clear and enough evidence to actually support the FDA. Now, the FDA has approved those technologies because the available evidence that this is a technology that is available and that are effective and safe as well. So once people in between the public and the physician, treating physician, once they know this, they believe this, then you will start seeing flow of patients. I mean, in our center, we have done almost more than 25 cases so far, and we participate in the global simplicity registry, and we are following our patients, and so far we see a very nice result. And when we go and educate our colleagues we share with them the results of these real-world data, and we show them how our patients are getting the benefit of this procedure.
Thanks, Dr. Nabil. In Australia, Prof. Alta, what's the main barrier? Is it reimbursement? Is it getting the patients, like what everyone has been saying?
Yeah, I think at the moment there are certain centers across the country, but not that many, that can do renal denervation as expert centers, but also reimbursement. I think absolutely that remains the main challenge because it's not covered by the Australian Medicare system. Yeah.
Prof. Atul, in Monaco, is it covered? Or
Yes. So we have three pathways of reimbursement. One for uncontrolled hypertensive patient despite 4 medication. So the very severe uncontrolled hypertensive patients are covered by our reimbursement scheme. Second, we have a pathway where Center of Excellence, so ESH Center of Excellence, needs to go to the file of the patient. And if they validate the indication, the patients get reimbursed for the treatment. And last, but this is really specific to Monaco, you know, Monaco is a special country. So we also have patients who are ready to pay for renal denervation. And surprisingly, but again, I would say it's a bias, we have a lot of these patients. So they don't want to take drugs. They want to have a procedure done. They feel comfortable. They want to be treated as fast as possible. So we have these three situations. One, the refractory complex patient. Second, the cases who are validated by excellent centers. And third, the patients who are ready to pay by themselves for the procedure.
thanks, Dr. Atul. I think Monaco's approach seems to be fairly appropriate because we have sufficient evidence. We're writing it into guidelines and consensus, but we are slow to reimbursement, which is a real barrier in other countries. Well, unlikely to become Monaco here in Southeast Asia or Saudi Arabia, so we are challenged in that sense. Professor Chia is from primary care. I don't know whether you're online. Prof. Chia, people have been talking about collaborating with primary care. Everyone needs your patients, and is it your perception also that if there is a hypertension clinic to refer to, it's easy for you, or how do you engage primary care to create this network of care for this?
Yeah, thank you. I think what is happening in Malaysia, the primary care doctors are burdened with managing patients with all kinds of illnesses, not just hypertension, but hypertension definitely is part of the burden of care. Probably, you know, in my own clinic, in a tertiary center, primary care in a tertiary center, I would say 70% of my patients have hypertension. So it's a huge number. Having said that, I looked at the prevalence of resistant hypertension, uncontrolled and resistant. It's about 8% only. So it's not that high. So if I've got 10,000 patients, hypertensive patients on our register, that actually accounts for quite a number of patients. And obviously they have to be carefully screened and so on and so forth. What is happening out? I'm luckier in the sense that I'm in a tertiary center, so I have access to ambulatory, I have access to all the tests. But for the majority of primary care doctors, particularly those working in the clinic health centers, there are many, there are about 1,000 health centers. Some are bigger, there may be about 5 or 6 doctors, some may only be a lone ranger. But these are the doctors who have not heard too much about renal denervation. Recently, I just had a teaching session with my students. I train about 800 students in primary care. And when I asked how many of you have heard about renal denervation, there were not many hands. And even of those who have heard, they don't know too much about it. I think what has happened is after Simplicity 3, everything was quiet. And then COVID came, of course, in the last 3 to 4 years, hardly any CME on renal denervation has been done. It's all on COVID, and COVID. And so I think it's time for us now that the renal denervation is recommended in guidelines, that it's time to revise this and re-educate, or at least start to educate the doctors again. The problem, of course, they also have is they're unable to do most of the screening. And I have proposed that the bigger centers should have at least the ambulatory BP monitor because it's not expensive and not difficult to do. Of course, the alternative is to do home blood pressure measurements. Many of our patients, more than 60% of our patients, have a home blood pressure set. So that could be the first point. And of course, checking the adherence, and then only the secondary causes. But it needs a concerted effort. And I have proposed to the primary care doctors is that within a region, because there are small clinics and a bigger clinic, that bigger clinic can be served as the initial screening center for those who are uncontrolled. And then after that, refer on to the specialist center that will do more sophisticated work with the option of needing renal denervation. So I think back to square one, we actually have to start re-educating the doctors more specifically rather than a very general announcement of it, for them to help to screen patients who really need to be considered for renal denervation.
So you hear that, TK, more campaigning work for you. Dr. Chia, just a quick one. Which group of patients currently you think you guys are referring to tertiary care? When do they qualify as uncontrolled or refractory hypertension?
Yeah, I think firstly, of course, is we have to document the uncontrolled. And sometimes we know uncontrolled blood pressure may not be, it may only be one visit, and then the other visits they are controlled. So therefore, these are special circumstances where in the one visit, they are not controlled. And that's why it needs several measurements to prove or to document that there's uncontrolled. And of course, we know adherence is a huge issue. But having said that, if a patient is not adherent, it doesn't exclude them from needing denervation, because some patients, no matter what they do, they cannot adhere, or they are adhering but not controlled. And this is what I find also in my clinics, because the patients are older, they tend to be very adherent and they're still not controlled. So that's the first step, to identify people who are uncontrolled. And then, because ambulatory is not available in most clinics, is to do the home blood pressure, ensuring adherence, and then from there move on to do try to exclude some secondary causes. So that's how I think the approach will be for the primary care doctors.
Thanks, Dr. Shah. My fault. I presume actually most doctors know about RDN is, again, my very narrow focus. So I ask people not to focus too much on the procedure, but I see a lot of questions asking how it's done, how it's performed. TK, before Dr. Nabil illustrate his case and show some images, maybe you can just tell us how the procedure is done in just a few words, TK.
Yeah, thanks. I'm sure it'll be illustrated when they demonstrate, when they show the cases, but just very briefly, it's a little bit like coronary angiogram, a bit the same, but not quite the same, right? We normally use a femoral approach. So a sheath is inserted in the femoral artery, and through the femoral artery, we insert a tube called a catheter, and the tube goes all the way to the renal artery. It's a hollow tube, the catheter, and through the catheter, we introduce the renal denervation catheter, which is like a thick wire, right, with electrodes on it. And through this ablation catheter, we deliver radio frequency energy in the renal artery. This energy generates heat and destroys the sympathetic nerves, which lie on the surface of the renal vessels. In general, that's the principle of it, right? We targeted a lot of, not just that, we used to do only the main artery, but now we also do the main branches. So any renal artery with the branches greater than 3 millimeters, it's also targeted for this therapy. So you have to do both sides. And the patient has more than one artery on each side. Sometimes the patient has 2 renal arteries, so some even 3. So if they're of significant size, all of them have to be treated. So in general, renal denervation, this is using radio frequency. It's putting a wire, a catheter with electrodes into the renal artery, deliver radio frequency energy through that wire using a power generator that generates heat and destroys the nerves. But of course, there are other ways to destroy the renal arteries. So you can use ultrasound. So there's an alternate device where a special device is placed in the renal artery, and that can deliver ultrasonic waves to destroy the nerves. Yeah, there's also other technique, which I think is a little bit more invasive, which is the injection of alcohol through the walls of the renal vessels, and using that to destroy the sympathetic nerves. But I think that is not very not many people want to do that. It's a bit too, it sounds a bit more invasive. Yeah.
So under local anesthesia, femoral approach with some sedation on board is what you usually do.
Yeah, from the practical aspect,
Yes, Paul, feel free.
Can I just ask TK here? Would you screen as part of the screening? Would you have done some imaging prior to getting the patient on the table for RDN, such as ultrasound or even CT or MRI to look at the renal artery anatomy and help you plan ahead? Or, on the day you just do the renal angiogram and just get on with it?
All right. For the majority of patients, we actually do the renal angiogram on the day itself. So we do not have imaging before they come, except for some patients who come from quite far away. So so for those patients who are from more distant hospitals, if the facility is available, we do ask them to do imaging, because we don't want the patient to come all the way and it's not suitable case for renal denervation, because of renal artery stenosis or something else. Yeah. So for that, we tend to get them down elsewhere. But majority of patients, they have not. We do it on the day itself. Yeah.
Prof. Atul, your comments.
Thank you. Thank you for TK for your nice comments. Just three quick comments. One, it's suitable to do at least a CT scan. Why? Because we have been sometimes in a situation where the classical angiogram do not allow to exclude fibrodysplasia, especially in patient in women. So we had these issues where we discovered late fibrodysplasia and we couldn't identify them with the classical approach of the angiogram. Second, we have learned that treating accessories arteries is as important as treating the main. And so in order to prepare the procedure, having a very extensive assessment of other arteries, and there are some very nice pathophysiological data showing that the level of innervation of accessories, sometimes of polar arteries, has an impact on the quality of care. So you need to have an extensive treatment of all arteries and branches if they are involved in renal vascularization. There have even been studies showing that the type of nerves which are involved in sympathetic increased tone are not necessarily the same. And so it's very important to assess the anatomy, but also the presence of accessories and exclude especially fibrodysplasia, which is not always something you can exclude when you do a classical angiogram.
Thanks, Prof. Atul. Of course, it would be good to have all this pre-planning information available. I do agree with that. Maybe we'll move ahead and get Dr. Nabil. It's 4 a.m. now in his time, so we're going to get him to go first so he can show us a complex case, and we'll dive more into the procedure proper, the technical aspects.
Thank you, Prof. Jack. So let me share my screen here. You see the you see the screen?
Yeah.
Okay. So I'd like to thank this esteemed panelist to give me the opportunity to present a case that we have done a few months ago. So let me just dive into the case, and then we can have some time to discuss. So our patient is a 52-year-old female who was referred to us from an outside facility with resistant hypertension. She has type 2 diabetes, for which she is getting metformin and dyslipidemia on atorvastatin. She has been diagnosed with hypertension for 20 years. She's been followed by a community cardiologist who placed her on fairly multiple number of medications that we'll review in a minute. She had a significant history of pulmonary embolism that happened after a C-section 13 years ago. She received anticoagulant for 6 months, and currently she's not on any oral anticoagulants. Her usual systolic blood pressure runs in the 180s and the diastolic runs in the 120s. She denies any chest pain, but complains of dyspnea on exertion with NYHA class 2 for the last few months. She has a very significant family history of hypertension. Her mother actually died because of subarachnoid hemorrhage, and her father, sister, as well as maternal aunts, they all have hypertension. Her blood pressure medication, right before during the time when we actually followed her, before we considered her for the procedure, she was on these medications. So irbesartan, hydrochlorothiazide combination, so say 312.5 milligram once a day. She was also on nifedipine, 60 milligram BID, carvedilol 25 BID, and in addition to spironolactone 100 milligram once a day, prazosin 1 milligram once a day, and isosorbide dinitrate. In our clinic, we actually added clonidine 0.1 milligram BID, and we introduced hydralazine as well, 25 milligram TID. Her ECG showed a normal sinus rhythm, no significant abnormality on the ECG. However, the echo showed mild concentric left ventricular hypertrophy with normal systolic function. She also has grade 1 diastolic dysfunction. There was no major valvular abnormalities. Her initial workup, including renal profile, thyroid, liver function tests, were all within acceptable limits. Her cortisol, metanephrine, renin, as well as aldosterone were within normal limits. Before I go into the case, any comments from our from panelists?
What is her body weight and height and BMI?
Actually, I don't have it right on me here, but she has an average body weight. I would say around 65. She's definitely less than 70 kilogram, and her height is around 165. So she's not obese. And sleep, we have also done a sleep study on her, and we excluded obstructive sleep apnea as well.
So that definitely, based on medication, really a refractory case. I was wondering, any other comments or observation from the other panelists?
Yeah,
Any
maybe
questions?
have you checked the presence of drugs in the urine or plasma? Have you done toxicological testing?
Yeah, so we did not do that. We asked her if she's using anything. She denies that. She works as a teacher, and she did not look like a patient who uses illicit drugs. And here in Saudi Arabia, to do a toxicology screen, we have it's a little bit more complex than other countries. If we have somebody who we feel that he has any problem with substance abuse, and we want to do a toxicology screen, it has to go through pre-approval first from the authorities.
Sorry, Nabila. My question was testing if she was taking the drugs like hydralazine.
Oh yeah, sorry. Yeah, I mean, she tells us that she's taking the medications. We did not test her medication in her blood sample. But she looks like she's a fairly reliable person.
Thank you.
Usually we don't routinely check that. One surrogate that we usually do is they've been filling up their prescription on time. They don't have a lot of spare drugs on board, and they always ask for a prescription to buy drugs. So that's one good surrogate marker. But great case so far, Dr. Nabil. Any other comments or questions? Professor Chia?
If I may comment, I think studies have shown that doctors are actually very poor at assessing patients' adherence to drugs, in the sense that we ask them in our usual cursory, are you taking your drugs? And the patient automatically says yes. But I think that's besides the point, because if this patient is already educated, if she's a teacher, that this is going to be a potential problem if she doesn't take her medicines. Even if she says she's taking it, and it is not controlled, obviously she has a problem of adherence. And no matter what we do, she will still have a problem of non-adherence. And looking at the list of drugs she's on, she's going to have problems with it. So I think in such instances, where patients have problems with adhering to the drug, there is still maybe room for consideration of renal denervation because she's never going to get controlled anyway. You might as well consider her, evaluate her, and see whether she's agreeable and suitable for renal denervation to help maybe not get her to the target, but at least if you lower the blood pressure by 20 millimeters from her 180, you're going to achieve a lot of benefit for her.
My only comment is that looking at her list of drugs, perhaps this conversation could have been moved a bit further upstream before clonidine, prazosin, isosodalide. It really looks like a huge load of medication. And desperation before they reach you. Yeah, but maybe we can carry on.
Okay, so we explained the procedure to her, and that was actually the reason she was referred to us to consider this this procedure. So we obtained an informed consent. We explained the pros and cons of the procedure, which is fairly safe based on the available evidence and as well as on practical cases that we have done. So the procedure, usually we do it under deep sedation because during the actual ablation, it can be a little bit painful. That's why we get anesthesia with us to do the deep sedation, let the patient sleep. It's not general anesthesia, but it is a deep sedation like cases with TAVR. We got an ultrasound-guided right groin axis. We established a 6 French sheath in the groin, and then we usually start with doing a non-selective angiogram in the abdominal aorta, just to identify the origin of the renal arteries, as well as to look for any accessory renal arteries. And majority of our patients, actually, before we take them to the cath lab, we do a CT angiogram, as you guys mentioned, because we want to make sure that we're not missing any accessory arteries, as well as to identify if there is atherosclerotic disease and significant renal artery stenosis that would make the procedure inappropriate. And then we go for a selective angiography to the renal artery. So just to show you here, what we usually do, we need to identify the area where the main artery is, as well as the main branches, but we should stay away from the actual parenchyma of the kidney. So after do a selective angiography, we identified 2 major branches, and then we go into each one of them. We pass our workhorse wire. In this case, I usually use BMW of my workhorse wire, and then we advance our catheter here, and we deliver the ablation in the lower branch here, and then we go to the next, the upper branch, and then we deliver our therapy, and then we go to the main artery, as you see here, and then we make sure that we ablate enough points in the renal artery and the main branches as well. Then after that, we get an angiogram at the end of each renal artery to make sure that there is no immediate complication. As you see here, there is no dissection or injury to the renal arteries or the main branches. And then we switch gears and move to the left, to the other side. So as you see here, again, there is the left renal artery here. It gives 2 main branches, and then the renal parenchyma here starts. So we usually stay with outside the renal parenchyma, but into the main renal artery branches. And then we advance our wire, and then over the wire we go with the catheter. As you see here, it has 4 points, so we deliver our therapy in the upper branch, and then Then with the help of the guide wire, we go into the lower branch, we deliver the therapy over there, and then we end with the main branch. And then at the end of the procedure, we do a selective angiography to make sure that there is no major complication that can happen. So let me just show you here that these blips are actually expected to happen as long as we don't have any injury to the vessel, but this actually gives you an idea that this area has been treated successfully. And then we followed this patient for the last 6 months so far. But let me show you, this is straight out of power chart. I pulled out her systolic blood pressure measurements. So this is the time when she was referred to us. This is her systolic blood pressure was usually up in the 170 to 180. And then we introduced some of the other drugs, the clonidine as well as the hydralazine. Her blood pressure was running around 150 at the time. And this is the time when we brought her into the cath lab, and we had a nice drop in her systolic blood pressure at the time of the admission. We kept her overnight. And then we followed her very closely, and it's very important to keep in mind that we did not discontinue her medication. We kept her on the medications at the time of discharge. We kept a very close eye on her, and we followed her in the clinic, and each one of these marker here represent 1 month. So we brought her every 2 weeks since then, and her blood pressure, systolic blood pressure, was around the 120, 125. So just this, you guys have seen this slide before, and it just shows you that from the available evidence, these are 2 meta-analyses that showed the reduction in major cardiovascular events, including stroke, heart failure, ischemic heart disease, cerebrovascular disease, and cardiovascular death actually are reduced proportional to the amount of reduction in blood pressure. The lower you reduce the blood pressure, the better the outcome in reducing these major cardiovascular events. As a result, the ESC have changed the recommendation recently, and they included RDN as a safe and effective treatment to control blood pressure. And these are the conditions that we can consider renal artery denervation in uncontrolled resistant hypertension, which is defined as office blood pressure more than 140/90, or confirmed by 24-hour ambulatory blood pressure more than 130, and treated with 3 or more blood pressure medications and eGFR of more than 40 or more based on the available clinical trials. Or patients who are intolerant to medications, and we should always take patient preference integrated in the decision making process. And you should go through a multidisciplinary team. And I just wanted to also share with you that renal denervation have shown effective reduction from the multiple patient populations, and this is from the Global Simplicity Registry that our hospital is actually participating in. This is resistant hypertension, patients with diabetes, atrial fibrillation, chronic kidney disease also are included, isolated systolic hypertension, patients who are elderly, patients with coronary artery disease, as well as cerebrovascular disease. You can see there is an actual very consistent reduction in blood pressure across all these patients with multiple comorbidities from the cardiac standpoint. And this is again from the same registry. It shows that those patients who are considered high risk, whether based only on the blood pressure numbers, like our patient here, or patients who have other risk factors based on the grade of the blood pressure, all these patients have shown a reduction in their blood pressure measurement. Again, the office systolic blood pressure is being reduced, and we so far we have enough evidence up to 3 years and longer actually of sustained reduction in blood pressure in these patients, whether we are measuring the office systolic blood pressure or the 24-hour ambulatory blood pressure monitor. Again, now we start seeing more patients who at baseline, we used to see this red measurements of 180 or 160 and above. As you see here at 3 years in this registry, we see it now the green the color is started to show up here, and the red color is actually being reduced. So it's a very effective sustained result so far for up to three years. Also, the number of medications, although not statistically significant, but there is actually a trend toward reducing number of medications that are used for hypertension as we go with time. Just to conclude, so there is a clinically meaningful and statistically significant blood pressure reduction in real-world high-risk patients population in the Global Simplicity Registry. Blood pressure reduction of 16 millimeter of mercury in office systolic blood pressure sustained out to 3 years with a reduction in medication following renal denervation. And RDN demonstrated consistent blood pressure reduction across a variety of high-risk patient subgroups, including advanced age, diabetes, atrial fibrillation, chronic kidney disease, isolated systolic blood pressure, prior stroke or MI, who are taking average of 4.6 medications. With that, I will finish my presentation. Thank you.
Thanks, Dr. Nabil. Indeed, very gratifying case to do and show effect. But I must say this group of patients is not common, but when it does come along, it's very gratifying. And I do agree with there's effect. There are a couple of good questions from the audience, so I'll ask that first of you. Raja asked whether if the blood pressure is so bad, why is LVH only mild on the echo? And could it be that she has a white coat component, and should 24-hour ambulatory blood pressure be done rather than office measurements to adjudicate the outcomes, as well as for the procedure? And another participant asked about fundoscopic findings as well, whether pointing to other end organ injuries. Dr. Nabil, you want to take this?
So, I mean, we part of the being part of this global simplicity registry, we have to report the 24-hour ambulatory blood pressure on all of our patients, and we do that as part of our protocol. And all these patients demonstrated the presence of uncontrolled blood pressure. So we have done that, but it's just that I didn't have the result of those. But they do not go for renal denervation if we believe that blood pressure or hypertension is a questionable problem here. But all of our patients, they undergo ambulatory blood pressure monitor. And so the other fundoscopic findings, I mean, we don't do that in our clinic, but we refer them to ophthalmology for all patients with hypertension and diabetes as well. They get their follow-up related to eye examination in the ophthalmology clinic. But what we usually do in our hypertension, we have a dedicated hypertension clinic where we make sure that the patient first are reliable in taking their medications, and we make sure that the secondary causes of hypertension are being ruled out before we proceed with this procedure.
Thank you, Dr. Nabil. Any comments from the panelists, Dr. Siripon?
Yes. I would like to ask about, are you record hemodynamic blood pressure during procedure, pre-procedure, and immediately? Is it down? immediately?
So yes, as I showed in the graph that I showed, actually I pulled it out from Power Chart. That's a snapshot of our recorded blood pressure. Any time that was the blood pressure taken during our encounters with this patient are being recorded and plotted in this chart. So as you see in the chart, once we started with the blood pressure that is really high, we added few centrally acting blood pressure, antihypertensive. Blood pressure came down a little bit during the procedure. We had a very nice reduction in blood pressure at the time of the procedure, and in the following day, we see a little bit drift of the blood pressure in the following visits. But so far, up to 5 months for this particular patient, her office systolic blood pressure as well as 24-hour ambulatory blood pressure are all within the acceptable limits. And we need to keep in mind that she's still on her antihypertensive medications that she came to us on, but we were able to stop the clonidine and hydralazine as well.
Thank you. Dr. Chia, your comments?
Yeah, I was about to ask whether there was any change in her antihypertensive medications, because I think there's two important things here. One is managing the patient's expectations in terms of her pill burden. Secondly, also to manage the expectations of the referring doctors, because most of us, when we were rather novice to all these things before all the data became available, we all think, or at least I was one of those who initially thought that once we do the renal denervation, many of the medications can be taken away. And this is where we need to address the expectations of the patient and the referring doctors, that the patient may still need to be on the same number of medicines. Maybe one or two can be taken away, but the greatest advantage of doing renal denervation, because they'll then ask, why do I need to do renal denervation if my pill burden is the same, is that now you are controlled. And of course, we see in this patient the dramatic fall in blood pressure to very, very well controlled 120 millimeters of mercury. So that's one thing we need to discuss with the patients and the doctors as we are bringing up the potential for renal denervation.
Thanks.
I
Thanks
agree
so
with
much.
you, Professor. I have been asked to, as an expert opinion in a lawsuit case that happened here back in Saudi Arabia. Right now, I'm in the United States, but in Saudi Arabia, I have been involved to give my opinion regarding a patient who actually sued his doctor in the private section, where he told, or the complaint was actually that he expected that he will get rid of his antihypertensive medications. And this is a very important. So first of all, as you mentioned, you have to set a realistic expectations to the referring physician as well as to the patient. Number two, and we learned this, to be honest with you, we learned this the hard way. Our program is running for now almost 3 years, but we learned this through the hard way. In our first few patients, we removed their blood pressure medications early on, and we saw a little bit rise in blood pressure in these patients. And this is very important. These patients need to be closely monitored right after the procedure, and then they should be followed closely in the clinic. And this is the good thing about being part of this registry. All these things are mandated by the registry. To be part of it, you have to follow your patients. You have to report all these things and findings to be part of the registry.
Thank you. Thank you very much. There are one or two questions on complications. So Paul, maybe you can take this one. Is postural hypertension common after RDN, and is it always a success, like what is documented in registry and RCTs? Meaning there's substantial blood pressure drop?
I think it's important that you choose your patient carefully. I think it's unrealistic to believe that any procedures are fail-safe and all your patients will achieve good outcome. I don't think that's realistic. The other question about postural hypertension is more tricky. I don't think I've done enough to answer that, but the cases I've done so far have not exhibited any of that. And by and large, this group of patients have really high blood pressure before they get recruited or get performed. So actually the blood pressure is high when they're standing or sitting or lying. So it's actually not so much of a problem. I actually also really enjoyed the talk early on by Nabil, but I have a question for him. When you are on the technical side, do you come across much renal artery spasm when you're performing your procedures? And is it routine practice that you put patients on nitrate when you're doing it?
So first of all, we usually do CT angio. Again, this was as we go. It's not only the technical aspect that we learn. Actually, we established our protocol now, and based on the recommendation. Although it's not standard in a lot of other hospitals, we do CT or MRA to identify the anatomy before the patient comes into the cath lab. But we routinely give intra-arterial nitroglycerin before we do our first selective angiography. And toward the end of the procedure, also we give nitroglycerin. I have never seen spasm, but usually just to make sure that we're not missing, we have the appropriate size of the vessels, and so we can have a better assessment of those things. But it's a routine assessment in our procedure to give intraarterial nitroglycerin.
Prof. Atul, you want to chip in here?
Yeah, just to add a comment about the side effects, I think it's really important because the difference between drugs and renal denervation is that you cannot go back. Once it's done, it's done. And so I think Paul's point was well taken. If you refer to the sympathetic surgical treatment of hypertensive patients, so 40, 50 years ago, there were a lot of complications related to sympathetic denervation, orthostatic hypotension, erectile dysfunction, fainting, etc., etc. What we have learned in the recent years is that there are, because the treatment here is selective, it's not affecting the main branches. It's not a gross approach, but it's a selective approach. The studies have shown that you don't have symptomatic or persistent orthostatic hypotension. You don't have chronotropic insufficiency. So whatever you could assess as being a side effect of denervating patients has not been seen so far in trials or in registry. So I think this is the safe side of the technique. But what is really important, and I think Nabil mentioned it also, and also our colleague from Malaysia, Professor Yokchin, is that you need to follow up the patient, because even though the drop might not be as important as stated previously in trials or registry, you might be in a situation where you need to adapt the treatment and stop one or two drugs. And that's really important because you need to decide which drug you want to stop. So it's easy when your patient are taking drugs with low level of evidence, hydralazine, alpha blocker, etc. It's more complex when your patient is having, as Alta mentioned, an adapted combination therapy with drugs with a high level of evidence, and you are not willing to stop an ACE inhibitor or an ARB or calcium channel blocker or a diuretic. So this is the tricky part. So follow-up is important, and expert assessment is important after the procedure in order to adapt the treatment.
Excellent comments, Prof. Atul again. Prof. Chia, your question or comment?
Yeah, to add on to that about why perhaps postural hypotension is not significant post-RDN. Again, I was one of those who thought that when I first heard about it, that there will be postural hypotension. I think partly, as Professor Atul has mentioned, it is very selective renal denervation of the renal sympathetic system rather than whole sympathetic tree. We know that the sympathetic system regulates blood pressure, transient rises in blood pressure. like when you stand up, you need the blood pressure to go up. Whereas the sympathetic nerves to the kidneys work through the RAS system, blocking the RAS system rather than just the sympathetic system transient rises, and so that's why perhaps that explains why we do not see postural hypotension, according to our thinking.
Thanks for that comment as well. TK, maybe you take these two questions as the last question for this segment. If you're setting up a program and you're afraid of renal artery dissection in the procedure, do you need to stand by renal artery stents and balloons, and what brands do you need to stock up? And in your lab, after you do a RDN, is there any simple test to say that your RDN is effective before you stop? TK?
Okay, I think renal artery injury is something that we always, not just dissection, but perforation and all these other things are something that we always tell the patient, so we take the consent for the procedure. But it's something that almost never happens, especially with the current generation of devices that we are using now. I think we almost, I've never, in our experience, we've never had any case of renal artery injury. But it's not
doesn't mean that
idea.
Doesn't mean that you do not need to stop the stents?
Yes, I think, however, it's probably a good idea to have at least a few pieces of the devices. The procedure itself might not cause injury, but if you are struggling to engage the renal artery with the guiding catheter, that part might cause injury. Yeah, so especially in patients with a lot of atherosclerotic aortic disease, that you might cause injury and cause a dissection. So purely for that reason, that you might need to have some renal stents on standby. I won't comment about the brands. There are many brands available. I think they're all equally good. So I'll just use the ones that your vascular team are familiar with, and so they have that on standby, just in case you need it. But almost certainly you probably will not need to use it. In regards to the blood pressure, okay. I think at the moment there's still no effective measures of the effectiveness of your treatment. And to make matters worse, unlike the case that we've just seen, most of the time the blood pressure does not come down immediately. It will take weeks, months, for the blood pressure to respond. So the blood pressure might look exactly the same after the procedure, and the patient might go home on exactly the same number of medications, right? And everyone feels disappointed, but you tell them, be patient, and you wait, right? And you wait, and in the coming weeks and months, the blood pressure will improve. Yeah. So I don't think there's any reliable measure at the moment that, okay, you've done enough ablation or the treatment has been effective, and this is a patient, this is a responder. I don't think there's any definite marker at the moment.
Prof, Atul, your comments, and then we probably have to transit to your talk as well.
Yeah, so thanks, TK. I think first, you're absolutely right, but this is also the danger of renal denervation. It is apparently simple, so everybody thinks he can do it and perform it. But I think renal denervation should be done by people like TK, Nabil, who have experience, who are dedicated and who do it properly. Because if you go from TAVI or mitral clip to renal denervation, it's boring, and you are unable to assess the outcome of the therapy. But you need to do it properly. So you need to take time, you need to treat the arteries, you need to treat the accessories, you need to treat the branches. Second, the rate of complication is very low, but when it happens, again, you should be in a situation where in the cath lab, the interventional cardiologist is used to manage this type of complication. It's not difficult, but you need to put these devices into the hand of people who are able to manage the complication. Last, you're absolutely right, TK. There are no biomarker or there are no tools to predict who will be the right responders. And that's also an issue with the therapy. It's a black box issue. You do the treatment, but you don't know if the treatment will be efficient. The decrease in blood pressure when patients get out from the cath lab is usually related to anesthesia. And patients and physicians were at the early stage very happy. They thought, well, the procedure worked. No, the procedure didn't work. The anesthesia worked. And then the blood pressure goes up again. Now, what we know is that there are some clinical factors which are associated to a better response and which are mainly related to sympathetic overdrive, so elevated heart rate, high level of renin, elevated baseline blood pressure are usually good predictors of response. There are some data showing that doing stimulation of the nerves before and after could allow us to assess that the procedure was done correctly, but is not related to the drop in blood pressure. And we are still waiting for new biomarkers. So TK is absolutely right. Up to now, there are no significant biomarkers able to predict who will be the right candidate or the good responder.
Thanks, Prof. Maybe we'll get you to start sharing your case as well, so we can give
Sure.
you the benefit of the time as well. We have around 25 minutes to the end of the session.
Okay. So can you see my screen?
Yes, we can see it clearly. Please go ahead.
Good. Thank you. So yes, I've decided to go through another type of approach, not focusing so much on the interventional part, because this has been nicely done by Nabil, and TK is an expert in the field. So this is the case of a lady who's a 49-year-old woman with a 5-year history of hypertension, treated, as Alta mentioned, in a very classical way with the combination of a calcium channel blocker and an ARB for the last 3 years. And after a while, during late summer, she experienced leg edema, and amlodipine was stopped, and the combination therapy was changed to valsartan 160 milligrams and a diuretic, hydrochlorothiazide, as a maximal dosage. And unfortunately, a couple of weeks later, she experienced gout, and hydrochlorothiazide was stopped. So she was seen in the outpatient clinic with an ABPM showing that her mean blood pressure was elevated with a normal dipping pattern, normal no abnormal signs of variability, and this patient had a normal BMI and normal renal function. She had mild left ventricular hypertrophy with some abnormal diastolic pattern, especially the strain, the size of the left atrium, and an inversion of the E and A mitral flow pattern. The recommended workup has been done to rule out any possible cause of secondary hypertension. I'm not going to go to this, but this was nicely depicted by the chart flow of TK. And we started discussing about options. She was uncontrolled, hypertensive patient with a single treatment, which was valsartan 160 milligrams of mercury. So first we discussed about adding a heart rate reducing drug, a beta blocker or a calcium channel blocker focusing on the heart. But she loves to exercise, and she was not too keen to take a drug blocking her, reducing her heart rate. Then we discussed about spironolactone, but we reviewed the side effects, and she thought that the combination therapy with valsartan was increasing her risk of hyperkalemia, and so we decided not to go for this. Finally, we screened the opportunity of adding, as Nabil mentioned, for example, centrally acting agent like clonidine or alpha blocking agent, but we agreed that the level of evidence was low and the rate of side effects was still high. So we were still sitting in front of a lady who was having uncontrolled hypertension with monotherapy. We then reviewed other options. So we said, okay, there might not be a class effect, and if we try to give you another calcium channel blocker, which is not amlodipine, you could reduce the risk of leg edema. So we reviewed available calcium channel blocker in Monaco, but her perception was that she didn't want to go for the risk of recurrent leg edema. We went through other options regarding distal diuretics, but for the same reason as for spironolactone, we decided, because of the risk of hyperkalemia, not to add this to valsartan. Then we reviewed her lifestyle, and she agreed that she could slightly reduce her salt consumption, but the rest was okay. And finally, after 45 minutes of discussion, she also admitted that she was not always taking her pills due to adverse drug reaction. And so we started discussing about RDN. Now, my case is about patient preferences, it's about patient choice, but you see that the first burden is time. I mean, after 45 minutes of time, I came up with something which would help me to guide her through another option. So this is, I think, a key point. in the same way as what we were doing when we were treating patients with new oral anticoagulant drugs, where describing the advantages and disadvantages of VK antagonists versus new oral anticoagulant, you need to go to these type of approaches where you will take into account patient preferences. And I would also add patient experience, physician experience and physician recommendation, and come up with what we call the shared decision-making situation. In this case, it was driven by the option to go for renal denervation. And for that, you need also to go to the benefits and the risk of renal denervation. And we had to add 45 minutes more time to the already 45 minutes of discussion. Now, Professor Schutte has nicely mentioned guidelines which have been shared in the community recently. And in these guidelines, you can see that the use of renal denervation could be suitable for patients who are uncontrolled or who have serious side effects with drugs or poor quality of life. And let's assume that this patient was having drug serious side effects and a poor quality of life. She had normal renal function. We have been through the process of shared decision-making, and she was admitted in an experienced specialized centers with interventional cardiologists like TK or NABI. Now, the concept of shared medical decision and of patient preference is something which has been systematically addressed in various guidelines, whether the European guidelines, the US guidelines coming from the community of interventional cardiologists. And it's really something we need to focus about. It's not just about taking into account patient preferences. Patient preferences have also now an impact on the way administration will grant a device to be reimbursed or not. And our studies, we have done a couple of studies in the field, have probably supported the acceptance of these regulatory authorities to offer renal denervation to the patient. Now, if you focus on, let's say, 7 to 8 guidelines who have been recently published from Malaysia, because part of them are our colleagues sitting around this panel table, to Europe, from Taiwan to Spain, all these guidelines have some differential aspect, but they have a common thread, which is taking into account patient preferences. Wherever you live, wherever you are, patient preferences is key. And we and others have been exploring this concept of patient preferences for device therapy and try to see if there was a transcultural validation of this concept, and asking different type of questions to different type of patients. Are patients willing to get an intervention? Do patients want renal denervation or additional medication? Do they prefer renal denervation? And what are the perception of renal denervation when you ask physician and patient? Well, we have learned first that when you ask patient, all patients are not ready to go for renal denervation. Probably 30% are keen to go for renal denervation, whether you ask a Japanese patient or you ask a German patient. In these 2 observational studies, one we have done with Roland Schmieder in 2019, the other done by our colleague from Japan, Kairo, showing that globally, only 1/3 of patients would choose an intervention like RDN to treat uncontrolled hypertension. So this is really important. Every patient is not ready to go for an intervention for the management of his hypertension. Second, and this was very surprising, we thought the higher the level of blood pressure, the more your patient is uncontrolled, the more he's willing to go for RDN. And again, we were able to see that whatever your level of blood pressure, and this study nicely shows that, the ratio of patients who are ready to go for RDN is independent of blood pressure level. And this was, again, a surprise. We thought that when your blood pressure is very high, when you're uncontrolled, when you have symptoms, you are keen to go for an intervention. It's not the case. Last but not least, the perception of renal denervation between physician and patient is different. Physician will usually recommend renal denervation in patients who are looking like Nabil's patient. So patient with an increased medication burden, high level of systolic blood pressure, while patients, as I stated earlier, are keen to go for renal denervation independently of the level of blood pressure, independently of their level of drug exposure. What is really interesting is that what is a matter of concern for physician, and that's really important for the pathway. You remember what TK showed us, who is sending us patient for the procedure. The major concern for doctors is the invasiveness of procedure. It's not about controlling blood pressure or side effects, but it's really the invasiveness of procedure. So what we did a couple of months ago, we did a new type of study, which was not a survey. All the data I've presented up to now are surveys. So we ask patients, do you like or do you want renal denervation? We ask physicians, do you want renal denervation for your patient? In this case, we use a kind of different approach, which is called DCE, for discrete search experiment. Basically, we try to mimic the way the brain works when it has to make a decision. So when you need to buy a smartphone, you will not say, do I want a smartphone, yes or no? You will say, okay, I want a smartphone, the size of the screen, the brand, if the camera is working well, is it nicely connected to internet, the space of memory. And for every item, you will go through a pathway in your brain where you will say, okay, I know this phone is expensive, but because the screen is large enough, I'm ready to pay more. Okay? And that's exactly what we try to build in this approach, which is called the DCE approach, which is basically an econometry approach. It has been developed by a Nobel Prize of Economy to see how the brain is working when it has to make a decision. And using this approach, what we discovered is that while we agree that renal denervation is not something every patient wants, only 30%, what is really important for the patient is not depending on his level of baseline blood pressure, but what is really important, and that's what we learned in this study, was the amount of blood pressure drop the therapy was able to perform when offered to a patient. So if you want to convince a patient about RDN, you need to go to the impact of the therapy on blood pressure reduction. That's really important. And you see here that the office systolic blood pressure reduction was the factor which was related to the most importance in this approach, far beyond the duration of the effect and the impact on daily pills. Now, what we also did was to see if there was an impact on the expected effect of the drugs on the ratio of patients who are keen to go for renal denervation. And you see here that the higher the blood pressure drop, the higher the number of patients who are willing to go for the procedure. 7.5 millimeters is something you would expect, at least from the trials. And if you are able to offer 7.5 millimeters of drop in blood pressure, 1 out of 2 patients, so we are moving from 30 to 50% of the patients are ready to go for renal denervation. And the model, I was trying to explain you what we did, was to assume that you will not be prescribed an antihypertensive drug, that the therapy will last for 1 year, that you will not have any side effect. Interestingly, also for patients, what matters is what we call the benefit-risk ratio. And this was really very interesting. If the therapy is able to offer at least a drop of blood pressure of 2.5 millimeter, which is very low, the therapy is offering a higher level of blood pressure drop, well, patients were ready to accept a risk of almost 20%. This is really important. What matters for the patient and what a patient is ready to accept as a risk is not necessarily what a physician would accept or not necessarily what a regulatory agency would accept. This was a learning from this study. Finally, what you've learned is that when you are able to outweigh the effect of side effect, when you are able to offer a significant blood pressure reduction, the level of patients who are ready to go for the therapy can even increase from 50 to 76%. Now back to our cases. So we performed renal denervation, and Nabil has nicely described the technical approach. I will not go through that. 4 months later, her blood pressure was normalized when we assessed the ambulatory blood pressure measurement. As mentioned, we did not stop her baseline treatment, which was valsartan. She had no procedural complication, but when we did drug screening, we realized that she was not taking her antihypertensive drug anymore. So she was a candidate who moved from monotherapy to no therapy, and where basically in this situation, renal denervation was able to control her blood pressure despite her not taking any pills. Thank you for your attention.
Thanks, Prof. I must be quite amazed by your presentation. It's a tour de force in patient-doctor psychology, actually. So I really enjoyed it. Maybe I invite Prof. Alta to comment first. She talked about guidelines from the start. You finish up on the guideline recommended patient-shared decision-making beautifully. Maybe Prof. Alta, your comments about the case?
Yes, thank you very much. It was a fascinating presentation, Atul. Thank you for that. I have some comments, and that is on the DCE. I think discrete choice experiments are such a powerful tool, so much more helpful than surveys. But I wonder whether that DCE included an analysis of cost. Was cost ever a consideration for the patients or participants?
Very, very good question, Alta. So you're right. We didn't took into account the impact of cost.
Okay.
So I've been through the data quickly, but let's say that the patients who have been involved in this approach were 400 US hypertensive patients who were not involved in any renal denervation trials, who were basically a mild to moderate hypertensive patient who never experienced side effect with drugs, but the item cost was not included in the model. And I think it's a very good point. And the second study we are conducting now is going to take into account the cost of the therapy, because we felt that it's probably something which can influence the choice of the patient if he needs to pay for it. Because at the time we did the study, there were discussion about the reimbursement. So the cost will have an impact in countries where you need to pay for the therapy. And we hope that in most of the cases, the therapy will be reimbursed.
Yes, and I would think that, sorry if I can just continue that, I think that if obviously at the moment the cost of reimbursement is quite high, and therefore it would probably dominate that survey completely if it were to be included. So I do understand that it wasn't, but yes, I mean, if you go from the standpoint that it will be reimbursed in the future, absolutely, these patient decisions are quite interesting and remarkable. I just want to make a final comment. Apologies, Prof. Chia. I just want to make a final comment on the guidelines currently recommending, obviously, the RDN for resistant hypertension or uncontrolled hypertension on medication. But I do think there is potential for the field to move towards patients with only monotherapy or other conditions, or general patients with hypertension. I wonder how long that situation or the research need to continue before giving it as a first-line treatment, right? So we're absolutely not there yet, but I think once it's becoming more affordable and widely available, we want patients. We understand they don't want to take medication at all, and if it's a longer-term effect, it could obviously be a fantastic solution in general.
I think very important comment, Alta. First, there have been studies done in patients who have been weaned off their treatment. So the SOLO trial for the ultrasound device, the spiral off-med study for the radio frequency. But these studies were more there to assess the plausible biological effect of renal denervation and to avoid biases related to treatment. So what we have learned from this trial is that if you treat hypertensive patients with just renal denervation, you will see a drop in blood pressure, which is, let's say, similar to the effect of 1 to 2 drugs. Second, there are no morbidity mortality trial with the renal denervation, which is really something we are having and which is the added value of drugs. We don't have this with renal denervation. So you are absolutely right when you are offering the therapy, while it could be an asset to control blood pressure, for the natural history of our hypertensive patients, we are missing an important information. And that's probably why we will always start with drugs. Last, and that's why I decided to show you this case, is that you never know if your patients are taking drugs or not. So you might, the idea of the case was to say, well, we decided to treat patients who were apparently treated, and probably it could be the case that the patient presented by Nabil was not taking any pill. And we discovered that even this lady was not taking any pills. So I totally agree. We are not there yet to start with renal denervation, but we might treat patients who are not taking their pills, not saying or not sharing that with us, and so coming up with this type of data.
I just wanted to add to what Professor Atul did in terms of taking 45 minutes to come to the point of offering renal denervation. I think we need to think that we may not achieve what we want to do in one visit. Rome was not built in a day. And so therefore, sometimes you may need several consultations before you come to the point of patient wanting to make a decision about renal denervation. And I think that's fine. We don't give up, because this also happens to simple procedures like colonoscopies. I have patients that I recommend. They say, oh, no, I have nothing wrong with me. My bowels are good and la and all that. I said, never mind. You just go home, think about it, and then come back next visit when I see you, and then we can make a final decision. And the next visit, they come back and say, oh, yes, I will do it now. Why? Because they've checked with the internet, they've checked with their family, they've checked with their friends. And this is exactly what patients will do. Except for renal denervation, there may not be many patients that they can talk to who have done renal denervation. And that just gave me an idea that perhaps we should have a list of the patients who have undergone renal denervation, be it successful or not successful. And perhaps if the patients are agreeable, for potential patients to talk to them about the experience, the expectations, and so on and so forth, that may help them to make the correct decision in that sense.
All very good comments. Any other question or comments about this excellent case that Prof. Atul narrated? Yeah, Sarah.
Yeah. How to know is it time to RDN again after 1 year or 2 years in high blood pressure? In some case, you know that after RDN is very high blood pressure again after 1 year.
Yeah, that's a good question. I mean, experimental data have shown that in dogs, for example, when you do renal denervation, after 6 months, there might be a regrowth of nerves. And this is also something we know in our heart transplantation. When you do a heart transplantation and you put a new heart in the patient, you see a growth of the nerves and you see heart rate going down accordingly to the re-innervation of the heart. Now, regrowth does not mean that functionally the nerves are working. You might see an amount of nerves which are bursting, sprouting, but it doesn't mean that these nerves are working. Second, what we have learned from registries where you have a follow-up of patient at 1, 2, 3 years for the GSR, the Global Simplicity Registry, is that there is exactly the opposite. There's an amplification of effect. So you see blood pressure going down after 3 to 6 months, and it goes even down furthermore during follow-up. But these patients might have been started on antihypertensive drugs after the procedure. You don't know. Or these patients might have started to take again the pill they have stopped taking because they felt they have been to an intervention, their disease is something really serious, and they need to be treated. Last but not least, I think you cannot exclude the fact that some of the patients might have a new increase in their blood pressure after the procedure, not controlled with drugs, after a renal denervation procedure. And so there are two types of important information. There have been studies and publications showing the very long follow-up of the initial patients treated with renal denervation, some coming from the team of Australia, Markus Schleich and colleagues, other coming from Germany. But these patients were patients treated with the first generation of device, where the follow-up can be as long as 7, 8, 9 years, but again, where you don't know if they have not been treated in a different way. And last, this question is really important because it opens something we might discuss in the further years, which is the redo therapy. Should you perform renal denervation again? Or should you switch from one type of treatment, radiofrequency, to another type of treatment, ultrasound? But this will be probably a matter of discussion for our next webinar.
So I think we have run out of time. We have just 1 or 2 minutes to summarize the session. First, let me thank all my panelists and speakers. Wonderful session, great insights, and I learned so much. To help me summarize and close the session, I usually ask each of my speakers and panelists to give my audience one take-home learning point about this session. And maybe you can start with TK first. TK is quite used to this. What is your one learning point for this session for the audience?
I think the important thing is for the medical community, the doctors in particular managing hypertensive patients, to know that this therapy exists and to know where to send these patients to for this treatment.
So RDN is here and available, but we need to let people know about it.
Yeah, to let them know that RDN is back. Yeah.
Yeah, RDN is back. Sirapon, you have one teaching point.
Appropriate selection of patients is mandatory.
The right choice, get the right patient on table. Prof. Alta?
I think in this context, it would be not to assume that your patients are taking their medication.
Don't trust your patients. Okay, I like that. Prof. Chia?
I was going to add to that as well to say don't assume, because we are very poor at assessing on a consultation basis whether they're adherent. But that is not to say that even if they are not adherent, that we do not offer RDN, because as illustrated, they're going to take this drug for life. They are not going to be adherent. So the option is to do renal denervation so that at least their blood pressure is lowered to better levels.
Thanks, Prof. Chia. Prof. Atul, your teaching point?
Yeah, I think more generally, the voice of the patient is important because we also realize that not only for renal denervation, but if you take time to discuss with the patient, you might add another drug which is appropriate, you might increase his level of adherence, and eventually you might discuss about alternative solution like RDN. So the voice of patient is key, but for that you need time, or you need to delegate this task to other type of healthcare providers, like it's done, for example, in Canada or Spain.
So thanks everyone. I think the session seems to have veered into RDN. So in closing, I'd like to again summarize a pressing need to treat, diagnose, and control hypertension in our region better. It's causing great morbidity and mortality in our region, and we're not doing enough to address this issue. So a step back is that, first off, we still need this relationship. We need to constantly encourage our patient. The state-of-the-art management of hypertension is medication at the moment. It's just that it's difficult to get patients to comply and continue on with the appropriate dose medication. Implementation is a problem here, and we do appreciate folks like Prof. Chia in primary care that really is at the front end of helping this group of patients. When we have a hammer, everything looks like a nail. Whenever we have a new procedure like RDN, seems like suddenly we're interested in hypertension, but we shouldn't neglect it. So we thank folks like TK, Prof. Atul, Nabil for setting up programs and being centers of excellence and learning that we can refer patients for this option. I think the awareness is still pretty low. We're glad the FDA has finally approved this device for use. The trial results are pretty good post Simplicity 3. The trials are quite well structured to show that it's effective for patients who are on off meds, effective in a broad range of patients. So we know that it's effective. And more importantly, we know the procedure is extremely safe. It's safe to the extent that I think interventionalists tend to feel that it's a very boring procedure. But there are technical aspects of it. If you're not experienced enough, I think you're doing a disservice by doing this procedure in low volume places. So I think we still need a lot of learning to be had. And I like the presentation and the point made by Prof. Atul about shared decision-making. There's still room to address that group of patients that the blood pressure is still not well controlled for whatever reason. The worst case scenario is that the patient doesn't see you until he or she gets a stroke. So I think this space is still quite wide open, and we still need a lot more educational sessions and a lot more teaching to grow this space and interest among cardiologists and general practitioners. With that, I thank you for your time and attention, and keep safe, everyone. Bye-bye.
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 Bye-bye.